Alrighty, Pharm Week 2, Pain and Inflammation. Alrighty, so basic pain management strategies, those are pretty straightforward. So, cyclooxygenase inhibitors. So these are very common. These are going to be your aspirins, your acetaminophen, ibuprofens, naproxen. These are used they're over the counter almost always. They're used to suppress inflammation, to relieve pain, reduce fever, and most people are unaware of a lot of their common side effects like GI ulceration, stomach ulcers, small intestine ulcers, bleeding, renal impairment, kidney impairment. So the cyclooxygenase pathway, we've got our tissue injury of any kind. The broken or ruptured cells have membrane phospholipids. Actually, I don't even know if that's accurate. So somewhere we get some membrane phospholipids, whether they're released automatically or if it's because of destroyed cells, I couldn't tell you. They turn into arachidonic acid and then are split into the COX-1 pathway and the COX-2 pathway. The COX-1 pathway forms cytoprotective prostaglandins, while the COX-2 formation or pathway forms inflammatory prostaglandins. And we'll get into those in a bit. Cyclooxygenase itself is an enzyme that is found in all tissues and helps to regulate multiple processes. So, for example, they produce prostaglandins. Most of the time, cyclooxygenase is meant to produce some sort of a prostaglandin as like its only thing it does. Those prostaglandins, depending on where they're created or where those prostaglandins then travel to, denotes what kind of an effect they cause. So we've got prostaglandins that promote inflammation and sensitize receptors to painful stimuli, that protect gastric mucosa in the stomach from the acid, promotes the synthesis of thromboxane A2, which stimulates platelet aggregation or helps with clotting, promotes prostacyclin, which causes vasodilation, which is a good thing, generally. Promotes a vasodilation in the kidneys to maintain renal blood flow, and they help to cause fever and contribute to the perception of pain in the brain so that we can make sure that we have an appropriate immune response. Also in the uterus, it's used to promote contractions at term. So as you can see, cyclooxygenase is an enzyme that is used in an abundance of sources or places in the body for multiple different reasons. Hopefully you all can see this. These are actually from the Lehne, L-E-H-N-E pharmacology book. So there are different effects based on whether we're talking about the COX-1 or COX-2 activation or inhibition. So for example, in the stomach, COX-1, this is COX-2 in this chart, COX-1 in this chart. So in the stomach, it protects the gastric mucosa by producing prostaglandins, which are, they just help protect against the gastric acid. It helps with platelet aggregation, helps maintain renal function, and that's COX-1. So when we block COX-1, because we are blocking the protection of gastric mucosa with those prostaglandins, the stomach then is at risk of gastric ulcers. By blocking platelet aggregation, there's a potential risk of bleeding and the benefit of protecting against myocardial infarctions or heart attacks. And then because it helps to maintain renal blood flow, the opposite, blocking it, is going to cause potentially some renal impairment. For someone who's healthy, it's not a big deal. But if we're talking about someone who already has some level of renal impairment, This is just going to make it that much more worse, or that much worse, that much more, whatever. For COX-2, COX-2 causes vasodilation sort of all over the place, helps to maintain also renal function, promotes inflammation and the perception of pain at the level of the actual tissues that are injured, promotes fever, and helps again in the brain to perceive pain, better perceive it. And then in the colon and the rectum, it actually can cause colorectal cancer. So I don't know how that works. Blocking it, if we block COX-2, that means that what normally was vasodilation now becomes vasoconstriction, which poses as a myocardial infarction risk. And as with COX-1 up here, blocking COX-2 will impede on renal function, causing renal impairment. The benefit we have here is that we have an anti-inflammatory effect and an analgesic effect, which is just pain, helping with pain. Also, another couple benefits is that it helps with fever through antipyretic action, lowers the fever, and some more analgesia. And then another benefit that's kind of minor is it has some colorectal cancer protection because it counters this risk. Don't worry so much. This has nothing to do with this. Well, actually, it kind of does. So I'm going to take this out. Okay. So we've got basically four different classes of. Actually, that kind of works. There are four classes of cyclooxygenase inhibitors. We've got our first generation NSAIDs, which are going to be just aspirin. We've got our first generation NSAIDs that are all others, such as ibuprofen, naproxen. We have our second generation NSAIDs, also known as our COXIBs, and then we get acetaminophen or Tylenol. So there are generally according to this, four indications for using cyclooxygenase inhibitors: inflammation, pain, fever, and the prevention of myocardial infarction or stroke. So with our first generation NSAIDs, they are able to be used for all four. They're good for all four. Generally, the problem though is that aspirin has a greater chance for more side effects. So it's kind of a trade-off. With all of the other ones, they are good for inflammation, pain, fever, all others being like ibuprofen or naproxen, etc. But they do not have the prevention of MI or stroke because they don't have as strong of a antiplatelet aggregation factor. Second generation NSAIDs are really only good for pain and inflammation. They're not good for fever or MI. Tylenol is no good for inflammation, no good for MI or stroke. It's good for pain and fever. Let's see here. Okay, so the adverse effects of the four different classes is going to be that all of them pretty much have a risk of GI ulceration. With the COXIBs, it's a little bit less because they are a little bit more selective for COX-2, which gastric ulceration is more of a COX-1 issue than a COX-2 issue. But there is still some impairment of the gastric protection, and so you can still get some GI ulceration. It's supposed to be less. But Tylenol doesn't have that risk at all. There is renal impairment with all of them except Tylenol. There is a bleeding risk with both of the first generation classes, There is not as much of a bleeding risk with coxibs, and there is no bleeding risk with Tylenol. There is an MI and stroke concern with our ibuprofen, naproxen, and second generation NSAIDs, but there is no risk because acetaminophen only affects the central central nervous system rather than the peripheral, and there is no risk with aspirin with having an MI and stroke because aspirin has that extra boost benefit of specifically targeting platelet aggregation. So while there is some vasoconstriction in general, this aspirin tends to counter that by blocking platelet aggregation, making it so that they don't clot as easily. And then Tylenol is the only one that has any issue with liver damage with overdose. So looking at this, you kind of get the impression that for most things, if you got inflammation, you got to stick with one of the classic NSAIDs. But if you're talking about simply pain and fever, Tylenol covers both of them. And there's virtually no risk of side effects except for liver damage with an overdose. So make sure you don't overdose, and you should be a lot better taking Tylenol over anything else, unless you have inflammation or you're trying to prevent MI or stroke. That's a very specific population, and that's based on a direction from a physician, not just because you want to take it. All right. So COX-1, COX-2 are used to treat inflammatory disorders like RA, osteoarthritis, bursitis. They alleviate mild to moderate pain, suppress fever, and specifically ibuprofen is good for dysmenorrhea, so painful menses, periods. They also can suppress inflammation, but they have, as we just covered, a risk of serious harm, such as GI ulcers, renal impairment, from closing off some of those renal blood vessels, bleeding risks, and causing heart attacks and strokes. So our first generation aspirins, these are salicylates. That's just the kind of class that aspirin falls under. It is a non-selective inhibitor of cyclooxygenase, so that means it goes to both class or COX-1 and COX-2. Remember that salicylates aspirin are the irreversible form of NSAID inhibitors. So that's like being I believe it's a non-competitive antagonist. I think. I feel like that word's misspelled. So the pharmacokinetics, it's quickly absorbed. It's distributed to all different tissues and fluids, and excretion through the kidneys depending on the urine pH. That'll come in handy in a little bit with overdose. So we're going to be using this for pain, analgesic for fever, antipyretic for anti-inflammatory, and specifically for aspirin, suppression of platelet aggregation to prevent MI and stroke, and kind of a little bit for some cancer prevention in in the colon and rectum. The adverse effects, as we covered, we've got those GI effects, gastric ulcers, bleeding risks, especially if taken with anything else that can potentiate a bleeding issue, renal impairment because you're closing off those renal tubes or renal afferent arterioles. And then there's also, we'll come back to this in a second, of course, bleeding risks with pregnancy, and a hypersensitivity reaction is possible. Now, specifically for salicylates, we have the potential concern of salicylism and Reye's syndrome. So salicylism comes from basically overdosing on aspirin, and it begins to develop when levels are just slightly above that therapeutic range. The early signs and symptoms are going to be things like tinnitus, sweating, headache, dizziness, but eventually will lead to acidosis since aspirin itself is an acid. as we learned with pH partitioning in the slide before this, not the slide, the PowerPoint before this. And eventually that's going to lead to tachypnea and hypocapnia, which is low levels of CO2 in the blood, because they're trying to breathe off as much acid as possible to compensate for the extra acid in the blood. Reye syndrome is a childhood illness with a pretty high mortality rate at 20 to 30%. We have things like encephalopathy and fatty liver degeneration. And the suspected relation to aspirin usage in children is with influenza and chickenpox, because kids they have some pain with chickenpox or influenza, they have fever, parents are like, oh, let's go ahead and give them some aspirin to take care of that. Well, there seems to be a pretty strong indication that you should avoid it because of a risk of Reye syndrome. Instead, use acetaminophen. Just don't overdose them, and you will avoid that liver damage, and you'll have virtually, if not zero, other side effects. So contraindications: if they already have peptic ulcers, it's just going to make it worse. If they have bleeding disorders, it's just going to make it worse. Don't give it to someone with an allergy, because that's just going to piss off your patient, and it's wrong to do that to your patients. Give in pregnancy with caution. We want to try other things instead, because there is a risk of bleeding out with pregnancy. If we take it with anticoagulants like warfarin or heparin, of course, that's going to increase the bleeding risk with taking with aspirin. And similarly, if you already have GI ulcers, not already have, there's a increased risk for GI ulcers. Good grief, freaking pen. So if you're taking things like glucocorticoids or alcohol, that's going to further increase the inhibition of GI protection, which is going to lead to a better or higher risk of GI ulcers. Don't take it with ibuprofen or not acetaminophen. You can take it with acetaminophen. You cannot take it with other first class or second generation NSAIDs, because there will be a decreased antiplatelet effect from aspirin, because most of the time people take aspirin for the purpose of protecting against MI and stroke. And ibuprofen, ibuprofen, naproxen, they're going to have an increased risk of MI and stroke, and they're going to counter the benefits of taking aspirin in the first place. They're also going to potentiate the other side effects like renal impairment, GI ulceration, etc. ACE inhibitors and ARBs, they'll be covered in a little bit as well, a few PowerPoints on. They work on the RAS system, and they will further impair renal function when taken together with aspirin. And then don't take it with willow bark. I've never seen willow bark as a supplement or anything else. I don't know, people go finding willow trees and start munching on the bark, but don't do it if you're taking aspirin, since aspirin is a derivative of willow bark. I don't know who that guy is. With acute poisonings, if a kid takes 4 grams, which is a heck of a lot, most of the time with an emergency, they want to give patients with a heart attack, or actually we don't give patients with a stroke aspirin, I don't think. For anyone with an acute MI, we're going to be giving them aspirin at 324 milligrams. That's like the only dose of aspirin we give, so 4 grams would be a heck of a lot. I don't know why any kid, maybe they're just munching on it like candy. But if they take it, they're going to start off with compensated respiratory alkalosis, because their body, being a salicylate, is going to become very acidic, because aspirin's an acid. And so they're going to start off trying to compensate, but eventually they're going to go into respiratory depression, and then acidosis, hyperthermia, sweating, dehydration, eventually going into stupor, coma, and eventually death from respiratory failure. Treatment is, your ABCs first. We want to get them on a ventilator to ensure that we're keeping their respirations at a good rate and depth. We want to cool them because they're likely to become hyperthermic. Fluids to try to get as much of that stuff out of their system as possible. And then we're going to want to alkalinize their urine with sodium bicarbonate, which is like the primary way to try to get that aspirin out of the system. Because remember, aspirin is non-ionized at first when we take it. It enters the stomach, it's acidic, and it will go into the blood and all that, but it is attracted to highly alkaline areas of the body, and once it goes into a highly alkaline section of the body, like the urine, if we make it artificially very alkaline, it'll go there, it'll become ionized, which will make it impossible for it to be reabsorbed out of the urinary tubules, and it'll actually be trapped in there and it'll just be flushed out. And it's a quicker, better way to get it out of the system. And then we also can consider hemodialysis if it's a really bad poisoning. So our non-aspirin first-generation NSAIDs are like aspirin, but with fewer side effects that we've covered so far. All of these non-aspirin first-gen NSAIDs are clinically similar. We don't know why. Some patients do better than others with certain ones. So whichever one the patient prefers, whatever, go for it. Unlike aspirin, these are reversible inhibitors of COX-1 and COX-2. They do affect both COX-1 and COX-2 because they're first generation. All first generations are going to inhibit both COX-1 and COX-2. But these ones, unlike aspirin, are reversible. The principal indications of these are rheumatoid arthritis and osteoarthritis. These, you got to remember, do not protect against MI and stroke. Only aspirin can do that. The main three are ibuprofen, naproxen, and ketorolac. So ibuprofen, find this in Advil or Motrin, very commonly prescribed or suggested. Good for fever, moderate pain, arthritis. This is the one to go to for dysmenorrhea because it, for whatever reason, seems to work really well there. And it has, most adverse effects are going to be lower than aspirin, which is great. Naproxen is more selective for COX-1. It's going to be good for fever, moderate pain, arthritis. But it also has a lower risk of MI and stroke than other similar NSAIDs. Take that for what you will. Ketorolac, this is going to be a powerful version of NSAIDs. It's eventually the same as the other ones, except it is more powerful, equivalent to opioids, which is great. Not so great with the anti-inflammatory, but we don't need that because really all we ever are going to use it for is post-operative pain within that 5-day spectrum after surgery. Everything else is the same. So we want to teach our patients about multiple sources of NSAIDs because different NSAIDs can potentially get the same side effects, and putting them together, thinking they may be different medications, is just going to give you a really bad day or month or whatever. Now moving on to second generation NSAIDs. This is going to be celecoxib or Celebrex. These are selective for only COX-2. They don't affect COX-1. The uses are going to be the same as the other ones that we've covered. They have a lower risk, somewhat, for GI side effects. They still have, they were marketed as being, you don't have to worry about GI side effects. That's not true. They do still have some, it's just somewhat lower. Unfortunately, because of the fact that they are a higher risk for creating MI and stroke, they are not really as sought out as other ones, but they're also more expensive. It's been so bad that even like rofecoxib and valdecoxib caused MI and stroke so often that they've been withdrawn from use completely. Okay. And it's gotten to the point where the AHA had to even make a statement about them, saying most COX inhibitors, especially second generation COX-2 inhibitors, Increased risk for MI and stroke, so make sure you only take them under the guidance of a prescriber. Tylenol, acetaminophen, mechanism of action is going to be that it inhibits prostaglandin synthesis in the central nervous system. The other ones do it both in the CNS and the PSNS. No, the PNS, peripheral nervous system. I'm getting it confused with parasympathetic. So only in the PNS. Now I'm confusing everyone. Okay. Tylenol only is going to work in the CNS. The other ones work both in the CNS and the peripheral nervous system. They don't have any anti-inflammatory effects. So if you have something like an anti-inflammatory or an inflammation issue, you got to take ibuprofen or naproxen. I probably wouldn't take aspirin just because it has stronger potential for those other side effects. But if you don't have an inflammatory issue, take acetaminophen instead because there are far fewer issues with the side effects compared to the other NSAIDs. It's quickly absorbed, excreted through the kidneys, and metabolized by the liver via 2 pathways. So normally, acetaminophen, you take it and goes through the major pathway to form a non-toxic metabolite, and all is wonderful. Sometimes it goes through the minor pathway as well. It tends to go through both, just more often than not. More of it will go through the major pathway. More of it will go down through the minor pathway if a patient is also taking a lot of alcohol. If it does so, it has to go through this stage of being a toxic metabolite until glutathione then converts it from a toxic metabolite to a non-toxic metabolite. But if you take a whole bunch of alcohol, not only will you have more of the acetaminophen going down through the minor pathway, but you'll also have that alcohol depleting glutathione, making it so you get more of the Tylenol resting in this toxic metabolite state. And that's just going to cause all sorts of havoc to your liver. Don't do it. So in an overdose, the toxic metabolite is unable to quickly get converted by glutathione to a non-toxic metabolite, causing damage to the liver. Okay, and on top of that, the heavy alcohol users typically also have some form of pre-existing liver damage from the alcohol, so it's sort of this double whammy if you are a heavy alcohol user to begin with. So therapeutic uses, this says 4 grams per day. It's now been decreased to 3 grams per day as the maximum. You can use it for relief of pain, relief of fever. It is not anti-inflammatory. It is not associated with Reye's syndrome, so you're safe to give it to your kids. There are very few adverse effects at normal doses. Don't overdose it. Don't abuse alcohol while taking it. You may end up with liver failure. We don't want to give it to any patients who have liver failure, and we don't want to give it to patients who take more than 3 glasses, not grams, glasses per day of alcohol. Of course, that means there are interactions with alcohol, and it also will inhibit the metabolism of warfarin, leading to an increased abundance of warfarin in the body, making it so that you have an even higher risk of bleeding out. So if you have to take acetaminophen and you're already taking warfarin, check with your doctor first and see if maybe you might need to have the warfarin drop down a little bit if you have to take acetaminophen. That might be one of those rare cases. No, actually, I don't think you'd necessarily want to just jump on the other NSAIDs anyway, because those have even more of a bleeding out risk. Just talk to your freaking doctor. So acute toxicity, acute toxicity can lead to hepatic necrosis, hepatic failure, coma, and death. It's really bad. So early on, we'll have nausea, vomiting, diarrhea, sweating, abdominal pain. We want to identify it early so we can give them some acetylcysteine or mucomist. That is the antidote. So we want to teach our patients to focus on or to limit it to 3 grams per day. If you're undernourished, which means you're going to have low glutathione, since that's an amino acid, then probably it's not going to be 3 grams because that's now the new max. It'll probably be 2 grams per day, 2.2. And we want to educate them on, so basically if you haven't eaten well, limit it even more how much of that acetaminophen you're taking. We want to educate them on the risk of liver injury if they use alcohol. So if they are taking more than 3 drinks per day, I keep wanting to say grams. If they're taking more than 3 drinks per day, then limit it to probably at this point 1 gram per day of acetaminophen. We got to figure out what these new updated drug doses are. We also want to teach patients about how lots of over-the-counter drugs and prescription mixed drugs have acetaminophen mixed in with it. So if you're taking multiple drugs, not realizing there's acetaminophen, suddenly you may be overdosed, and that's bad. So teach them how to read the back of those boxes. Glucocorticoids are also known as corticosteroids, and they're nearly identical to the steroids that are produced by the adrenal cortex. We can have both a physiologic effect, which are those at low doses, and if we give them extra, then they can have a pharmacologic effect with those high doses. The physiologic effect is important for glucose metabolism. I don't know what that means. And then the pharmacologic dose is good for anti-inflammatory effects. So there are some distinct physiologic effects that come with glucocorticoids. They are used for a lot of stuff. They act on carbs, proteins, fats. They act on carbs, glucose in particular, to elevate blood glucose levels. And remember that with glucocorticoids, cortisol, this is something that's going to be released during the fight or flight reaction. So one of the things we want to do is get a lot of that glucose up so that we can use it for that emergency. So they're going to change, they're going to promote glycogenolysis, which is the breakdown of glycogen into glucose. It's going to promote gluconeogenesis, which is the creation of new glucose. And we're going to be suppressing the synthesis of proteins from amino acids, diverting the amino acids to the synthesis of more glucose. And we're also going to stimulate lipolysis, which is the breakdown of lipids, so that lipolysis can be used to gain even more energy. Unfortunately, if you take it long term, then that lipolysis can actually lead to a redistribution of fat. And that's why certain people who, if they have to take steroids for a really long time, they can develop, forgive the terms, these are the ones from the book, a pot belly, a moon face, and a buffalo hump on the back of their neck. Glucocorticoids also have cardiovascular benefits. It helps to maintain the integrity of the vasculature. I don't know why they consider this part of that subset, but that means increasing circulating red blood cells and neutrophils, decreasing other white blood cells, promoting vasoconstriction to help increase blood pressure, and decreasing capillary permeability to keep as much of the blood in the blood vasculature as possible. So during stress, we're also going to have an increase in secretion to help maintain blood pressure and blood glucose. Otherwise, you're risking hypotension and hypoglycemia. And then we can also give glucocorticoids, or they're important as a physiologic dose on their own, normally from the adrenal glands, in neonates to promote respiratory maturation. And that's why preterm infants often have to have, they have insufficient glucocorticoids naturally, so we may have to give them synthetic glucocorticoids for helping to mature the lungs. So there is a negative feedback loop with the hypothalamus, the pituitary gland, and the adrenal cortex for releasing glucocorticoids. It's just your typical negative feedback loop. So when giving it at pharmacologic doses, um, we're going to have the glucocorticoids. Well, actually, this is pharmacologic or physiologic. The receptors that glucocorticoids affect are actually inside the cell rather than being on the surface. And they don't actually change the activity of signaling pathways. What they do instead is change the production of regulatory proteins, so proteins that are used to regulate other processes throughout the body. I have no idea why that would be important for us in the clinical setting, but in case we need to know it. And then on the pharmacologic effects, which with the high doses, this is where we're going to be seeing those anti-inflammatory and immunosuppressant effects. We're still going to see a lot of that increase in glucose, the suppression of protein synthesis, and the fat redistribution for, forgive the terms, the pot belly, the moon face, and the buffalo hump. And then because of the fact that glucocorticoids can have some pseudo mineralocorticoid properties, being aldosterone, which is going to conserve sodium and waste potassium, we might, with some higher doses, see an increase in that sodium retention and potassium wasting. So that's always something to be consider when we see patients on regular high dose glucocorticoids, is the fact that we can have that mineralocorticoid aldosterone side effect. So there are short, intermediate, and long-acting steroids metabolized by the liver, renal excretion, yada yada. We can give it as either an IV when it comes to route, IV or PO, oral, and different ones, different glucocorticoids have different strengths. We also can give it, this isn't really talking about it, but we can give it also as a topical, which is good for things like eczema, dermatitis, etc. So for non-endocrine related disorders, there are a number of them that can be used, or that glucocorticoids can be used for. Allergic reactions, I just forgot the term for it. It's been a while since I've used my med words. Anaphylaxis, that's the one. Asthma, dermatologic disorders, you can either take it PO or use it topically. Inflammatory and autoimmune disorders like RA, neoplasms, cancer, or RA, so that goes up here, and then suppression of skin grafts, or suppression of skin graft rejection. So a person gets a skin graft from a burn or necrotic fasciitis, and taking these can help to reduce the chances of rejecting that skin graft. They can also be used in the end of life to promote appetite and the overall sense of wellness around 2 weeks prior to death. Helps give them a better death. Some of the adverse effects, of which there are many, we're looking at adrenal insufficiency. If we take it too long, then our adrenal glands are going to recognize that, hey, we aren't really needed because someone else is doing our job, so we're just going to go ahead and shrivel up. And then you try to reactivate them by just taking them off of glucocorticoids, and suddenly it's like, well, we're not ready yet, so keep on giving us the meds. There's also a chance for cataracts and glaucoma. With long-term use, there will be a rapid onset of high pressure in the eyes, which is really nasty to think about. Fluid and electrolyte disturbances can occur, and this is primarily through the pseudo-mineralocorticoid activation, leading to hypertension and edema. Because of the fact that glucocorticoids are going to massively increase blood glucose levels, our body can become glucose intolerant, which will then increase plasma levels, leading to potentially other inflammatory effects, ironically, from the extra sugar in the body. Growth retardation, I don't exactly understand why that is. I know it says decreased DNA synthesis and cell division. I don't understand what, how, and why. We can also get Iatrogenic meaning that it is prescriber or provider created Cushing syndrome, which is where we have an extra high level of, or like a pathologic level of steroids, glucocorticoids in the body. This can lead to then hyperglycemia, osteoporosis, bone wasting, muscle weakness, infection from an impact to the immune system, fat redistribution, skin striations. All right. Other adverse effects and infection because we are impeding on the immune system. Peptic ulcer disease because we are impeding on the protective factors, the cytoprotective mucus that develops inside the stomach against acid from gastric acid. We can have some psychological disturbances via insomnia or anxiety. Could even have delirium and hallucinations. And then when we use in pregnancy and lactation, there's a potential for cleft palate, spontaneous abortion, low birth weight, and growth retardation. I don't know what BF stands for. Oh, breastfeeding? Oh, okay, breastfeeding. So if you take it while breastfeeding, then growth retardation's a potential option. And here we see that moon faces, however that's pronounced, when this is what the kid normally looks like. All right, so there are some drug interactions to be concerned about. If we take glucocorticoids with any potassium losing drugs like other diuretics, then we're going to have that much more of a pronounced potassium loss. Digoxin is very sensitive to having a loss of potassium or working in a hypokalemic environment, and you can go into digoxin toxicity very quickly. So don't take it with, or be very, very careful taking it with digoxin and diuretics. Monitor that potassium. Of course, if you take it with NSAIDs, then we can have similar side effects in regards to the GI ulcers. We may need to take insulin or hypoglycemics to modulate works, but it sounds pretentious, to help with controlling the glucose levels in the blood, or if the patient already has diabetes, then they may have to up their doses of insulin and oral hypoglycemics. And an important thing to think about in the hospital setting is if you have a patient who's taking glucocorticoids, they may have to be on a temporary prescription of insulin because of their irregular blood sugar levels. And then vaccines may be problematic because the glucocorticoids will decrease the antibody response because of the anti-immune effects of glucocorticoids, making them virtually, there's no reason to take the vaccines. We definitely don't want to give live virus vaccines because those live viruses could just actually get the patient sick. In a healthy patient, the live virus vaccines should be no problem, but we don't want to give them to patients who are taking glucocorticoids. There's potential for systemic fungal infections. I just forgot the term for that. Systemic mycoses. Systemic fungal infections because we're affecting the immune system. And then we want to be careful giving it to pediatrics, people who are pregnant, and people who are breastfeeding. Let's see here. So adrenal suppression is a distinct possibility. And this slide's a little weird. So when we have a patient who is under a significant amount of stress, then we need to be certain to increase the dose to match what would be their physiologic, the physiologic dose they would have, which I think is 3 times the dose for 3 days. And when withdrawing the medication, we want to allow for adrenal recovery. So we want to taper slowly because if we don't, then there's a chance that they will go into, having taken it for so long, there's a good chance that they have adrenal insufficiency. So we want to give those adrenal glands an opportunity to sort of ramp back up and be ready to go once the medication's fully tapered off. All right, drugs for rheumatoid arthritis. This is an autoimmune inflammatory disorder of the joints. Treatment goals: relieve symptoms, maintain joint function, minimize systemic involvement, delay progression. We're going to start all of our patients with NSAIDs, and according to the current guidelines, there's also a potential that we're going to start our DMARDs, which are our disease-modifying anti-rheumatic drugs, DMARDs, early, since they might actually be able to arrest the disease process, just halt it, keep it where it's currently at, if it's given within the 3 months of diagnosis. That's assuming that we are catching it at the average same time frame in regards to the progression of the disease amongst all of our patients. If someone waits too long, they may have passed the point of getting any benefit from taking those meds early in relation to their diagnosis. And while waiting for those DMARDs to work, we also would consider then giving glucocorticoids to help to control a lot of those symptoms. So DMARDs come in 2 different flavors. We've got our non-biologic and our biologic. The non-biologic are cheaper than the biologic. The biologic can range from $14,000 to $35,000 per year. And as it is, the biologic versions are usually already combined with the non-biologic. The non-biologic is going to be methotrexate. This is the most rapid-acting form of DMARD, occurs in 3 to 6 weeks. It slows the disease progression by reducing the activity of B and T lymphocytes. So it's the B and T lymphocytes that are identifying wrongly as an autoimmune disease, that the synovial capsules of joints are the enemy. And so by reducing the activity of those guys, we are slowing the disease progression over time. But as you can imagine, that comes with a laundry list of side effects, since we're really screwing around with the immune system. So I don't know how hepatic fibrosis fits into this, but we're going to have bone marrow suppression, which means we're going to have a much higher chance of infections. We're also going to be limiting how much of a protective mucosa we have in the stomach, so we're at risk for GI ulceration, at risk for pneumonitis. I'm not even really sure what that is. And cardiovascular disease, I don't know why, which will then decrease life expectancy, fetal death. We want to then give folic acid to help with the GI and hepatic toxicity issues. And then we have our cytokine inhibitors, and cytokines, again, are those that are helping to promote that inflammation and immune response. So we got our tumor necrosis factor alpha and our interleukin-1. Each one has their own medication. So etanercept is going to be the one that we use to try to inhibit TNF alpha. And kind of interesting, etanercept actually, the molecules of etanercept contain 2 receptor spots that TNF alpha is actually attracted to. So when patients take etanercept, for every etanercept molecule, 2 TNF alpha molecules are attracted to it, they're bound to it, and they can't go about then acting on other tissues to potentiate that inflammatory reaction. And there is, of course, a risk of serious infection by taking etanercept, because we are limiting the action potential for our immune system. And rarely, weird, we can get CNS demyelination, like in multiple sclerosis and optic neuritis. That would be lots of fun. For interleukin-1 receptor antagonists, this is going to be, the purpose here is to prevent synovial inflammation and joint destruction, which kind of goes for everything here. The medication here is anakinra, and the only thing to remember is that it blocks interleukin-1, and you have a risk of serious infection. And that's it.